on my phone, and we're going to go ahead and start with our webinar today. So this is the Upper Midwest Telehealth Resource Center State of the Region webinar. We hold one every quarter, so this one is the third one for the year of 2023. I'm Amna Anwar. I'm a Senior Director at Indiana Rural Health Association and the Program Director for the Upper Midwest Telehealth Resource Center. With me is my colleague, Danielle Brinkley, who's a program coordinator at IRHA and UMTRC, who would be presenting this webinar with me. For those of you who are new to this group, the Upper Midwest Telehealth Resource Center is a program run under the Indiana Rural Health Association, and it is a grant-funded program through Health Resources and Services Administration under their program for Office of Advancement of Technology. We are your primary contact when it comes to anything and everything pertaining to telehealth for the states of Illinois, Indiana, Michigan, and Ohio. We are also proud partners with the National Consortium for Telehealth Resource Centers. We are one of the 12 regional telehealth resource centers, where the National Consortium of the Telehealth Resource Center is comprised of 12 regional and 2 national telehealth resource centers. You can see on this map, we are the ones in the Lilac region with our 4 states. The main aim for the National Consortium for Telehealth Resource Center is to implement telehealth programs for rural and underserved communities and help them by providing outreach, education, and technical assistance. I alluded to it in the previous slide. So what exactly do we do? Our main deliverable, our work is providing technical assistance. We aim to be your one-stop shop for all things telehealth. We provide individualized technical assistance, webinars and trainings, and for all of these up to 10 hours in a year are free of charge. Since we are grant funded, if anything goes above those 10 hours, and there is a contractual rate that we can provide if you have any interest in that. We also provide education through our webinars. There is a podcast, and there is also a live online library of telehealth resources, which are available on our website, the umtrc.org. The agenda for today's State of the Region is pretty similar to what we've had in the past. We will go over the federal policy and legislative updates and also the telehealth administrative updates that come down from CMS. And then my colleague Danielle is going to go into deeper detail about the UMTRC region updates. And we will also provide you some information about the upcoming events, which might be beneficial if you're interested in finding out more about telehealth in the region. So starting off with the federal policy and the legislative updates. The major legislative updates that occurred in the telehealth realm were in 2022, and the implications of which we are seeing in 2023. So there were 3 major things, which 2 of these were legislative and policy updates, which were the Consolidated Appropriations Act, which added an extension of 151 days to all of the telehealth flexibilities. And later on, the administrative side of the things took upon or incorporated all of those 151-day flexibilities in the physician fee schedule, which became effective January of 2023. At the end of last year, we were surprised and happily surprised with the omnibus, the Performance Enhancement Reform Act, that extended a lot more flexibility, almost all of the flexibilities that were introduced in COVID-19 till the end of the year 2024, that is December 31st is the last date for those flexibilities and extensions. So these were the 3 things, major things that happened. We will go over a little bit of detail of those, as probably most of you are familiar with what all of this was about, and then go over some of the important deadlines which are coming up when it comes to some of the flexibilities which were introduced during the COVID-19 PHE. Now, the public health emergency, eventually with multiple extensions, has ended. The last day was May 11th of 2023. Now, there were certain things which were supposed to come to an end on that day, which have since been extended. We will go over some of those details, but let's go over the details of the flexibilities that were added on to be extended till the end of December 31st, 2024. Now, these including flexibilities on the geographic restrictions on the originating site requirements, they were eliminated. FQHCs and RHCs as distant site providers for telehealth services, delay of the in-person requirement for the mental health services furnished through telehealth and audio-only services. All of these were, according to the Act, were extended till the end of the next year, that is 2024. And then there were also the use of telehealth to substitute for the face-to-face period for recertification for hospice care eligibility was extended, expanded list of eligible providers, OTs, PTs, and SLPs, and acute hospital as home initiative were also extended. Now, at that time, up until a few days before, the physician fee schedule that has been in effect since January of 2023 had not incorporated all of these, but we'll go over that detail later on in the proposed rule that has come out since July 13 of this year. With all those flexibilities being extended up until the end of next year, there were certain things that were supposed to come to an end May 11, 2023. One of those was the HIPAA rules notification of enforcement discretion. Many of you who practice telehealth were familiar with the HIPAA compliance rules as in any other healthcare entity, and they were applicable to telehealth as well. But many practitioners who joined telehealth or introduced telehealth practice to their practices during COVID-19 were not under those strict restrictions that HIPAA usually brings with them. Now, starting this notification of enforcement discretion was in effect since April 7th, 2020, and was intended to expire on the day of the end of public health emergency, May 11, 2023. However, because there was a lot of confusion if the public health emergency would be extended even further than May 11th, the OCR provided a 90-day calendar transition period, which will allow all the practitioners enough time to become compliant to HIPAA rules and notifications. Now, that deadline, the 90-day calendar day deadline, is coming to an end pretty soon on August 9, 2023. So there are multiple resources available on the UMTRC website in order to assess whether you are HIPAA compliant or not, because whether the compliance with HIPAA is breached or if it is not there, whether intentionally or unintentionally, there are financial and as well as the civil penalties that are associated with it. So you want to be sure that you are compliant before that deadline. Then there were anti-kickback and STAR clause. So public health emergency declaration in the March of 2020 triggered waivers to the STAR and other financial arrangement laws. And any financial arrangement with a physician entered in reliance on these exceptions has expired. So it has already expired. There has been no extension to these waivers. The waivers did not mean that everything in the STAR law was put on hold. Rather, they were available for specific referral and financial relationships that were solely related to at least one COVID-19 purpose. So shortly after announcing the STAR law waivers, the HHS Office of Inspector General, the OIG, announced that it would exercise its enforcement discretion under the anti-kickback statute for remuneration related to COVID-19 that was covered by 11 of the 18 STAR Law blanket waivers. These waivers gave hospitals and other entities the flexibility to provide free telehealth equipment to physician practices to facilitate the telehealth visits for patients who were observing the social distancing at that time. As of May 11th, parties operating under a relationship like this would need to revise this arrangement if it will continue after that date so that it meets all the elements of an exception. So there are certain exceptions to the STAR clause, and I have provided the link in these slides to take a look at those exceptions and if you can take advantage of any of those exceptions moving forward. Now, 9 of the 18 waivers permitted compensation above or below the fair market value. Any arrangements that relied on waivers related to fair market value that have continued after May 11th again must be reassessed to ensure payment terms satisfy the applicable regulatory guidelines going forward. Now, the waivers also permitted the loans between physicians and entities with interest rates below fair market value or otherwise made on terms not available from commercial lenders. Now, CMS has made clear that the repayment terms agreed to prior to the end of PHE can continue to govern the relationships after the PHE. The disbursement of loans proceeds after the May 11 would not qualify for the waivers and would need to satisfy the requirements of an applicable start law exception. Again, I have provided the link in these slides, which will be shared with you to see, look at all of those exceptions and if you qualify for any of those moving forward. The other thing which has been heavily discussed since it was introduced was the DEA proposed rule. It created a new option under exception 7 for the Ryan-Haight Act. The proposed rule had two options, basically. The first one was that a virtual first process where the practitioner or the initial prescription for the controlled substance can be dispersed for a period of 3 years, can be prescribed for a period of 30 days, not 3 years, 30 days, and then without conducting the in-person exam of the patient. But the medication is a non-narcotic schedule 3, 4, and 5 of controlled substances or the buprenorphine for opioid use disorder treatment. Again, the prescribed amount could not exceed 30 days. The other option was that a patient can be seen by one provider in person, and that provider or the practitioner can then refer the patient to the prescriber, who can then prescribe and have their consult via telehealth and prescribe the medications from Schedule 2 to Schedule 5 without personally conducting the exam. So the in-person exam was conducted by one practitioner, but then the patient could be referred to the other practitioner who can prescribe the controlled substances. What happened with this proposed rule? DEA received almost 40,000 public comments, as a result of which they drafted a temporary rule in the last week of when it was supposed to come in effect. And the key takeaways from this temporary rule is that more time is needed to review all the comments. The PHE flexibilities will be extended through November 11th of 2023. So all of the flexibilities are extended up until November. And if any patient, and the third one is that if a practitioner-patient telemedicine relationship is established on or before November 11th, then the flexibilities will be able to continue through November 11th of 2024. So we still have almost 1.5 years before all of these flexibilities come to an end. Moving on to the administrative updates. So physician fee schedule is usually released as a proposed rule in July, and then there is a comment period that is open to receive all the comments on that physician fee schedule, and then it becomes effective. I think it's finalized in November and becomes effective January of the next year. Now, this year, it was released on July 13th, and then this proposes policy changes to the physician fee schedule and other Medicare Part B issues effective on and after January 2024. We are going to focus mostly everything pertaining to telehealth that is included in this proposed physician fee schedule. The first thing that is you see on the slide is which was expected, because when the PERA was introduced or passed in December of 2022, the bigger question was that when will CMS incorporate all of those flexibilities till the end, as provided the extension till the end of 2024 in their physician fee schedule. And the idea was that they had plenty of time and they were going to do it with the new physician fee schedule, and that's exactly what they have done. All of the 2023 CAA's telehealth-related provisions have been extended till the end of 2024. To highlight a few, the waived geographic restrictions limiting the coverage of telehealth under Medicare to only rural and underserved areas have been removed up until the end of 2024. Again, beneficiaries' home as an eligible originating site. Then the expansion of the practitioners who could bill for telehealth services, occupational therapists, qualified physical therapists, speech language pathologist, and qualified audiologist. All of that have been extended till the end of 2024. Then the federally qualified health centers and RFCs, they can serve as distant site up until the end of 2024. And also the delayed in-person visit requirements for telemental health, and the coverage of audio-only services. So these were the major things which were extended up until the end of 2024, and this new rule has actually incorporated that legislative action that took place at the end of 2022. Now, the other thing which pertains to telehealth is that they have introduced a new method or a process for adding, removing, or changing services on the Medicare telehealth services list. So if you have been hearing various webinars on telehealth or are involved in telehealth billing and coding, you are familiar with the 3 categories that were introduced by CMS. So CMS plans to remove those 3 categories, category A, category 2, and category 3, and move towards a more two-way type of categories in which they're going to introduce the permanent or provisional as the 2 categories. And then they have also introduced a new process in this proposed rule, which is a 5-step process for considering the requests to add services to, remove services from, or change the status of the services on the Medicare telehealth list. Now, the aim is to remove the confusion that currently exists, because there are category 3 was actually introduced as a temporary space holder for some of the flexibilities. So all of this is going to continue till the end of December 2024 anyways. And then starting January of 2024, they want to move away from this three category taxonomy towards a 2 category, which permanent and provisional for the list of the telehealth services codes. The 5-step process that they are mentioning is introduced in the links that we will provide at the end, and there are various different steps which they will introduce to go through in order to add or remove services. The other thing which is going to impact the telehealth is that CMS proposes that beginning of obviously 2024, the telehealth services furnished to beneficiaries in their home be permanently paid at a higher non-facility PFS rate. Now, historically, CMS has paid clinician furnishing telehealth services at a distant site at the PFS's lower facility base, that is hospital payment rate, instead of the higher non-facility, the physician office rate. This means that the medical payment for the telehealth service is usually the same, regardless of whether it is furnished by a provider in a non-facility setting, such as a clinician's office, or a facility setting, such as the hospital outpatient department. Now, CMS, as a result of this, also proposes to modify the place of service modifiers, so that the 2 modifiers that were used, and if this is finalized, the place of service 10 or 10 would be used to bill for telehealth services furnished to a beneficiary in their home at the higher non-facility PFS rate. The place of service 02 would be used to bill for telehealth services when a patient is not in their home at the lower facility PFS rate. CMS justifies this proposed change in payment policy as protecting access to mental health and other telehealth services by aligning with telehealth-related flexibilities that were extended via the Consolidated Appropriations Act of 2023. Specifically, CMS expects the behavioral health providers will maintain telehealth services and in-person services going forward, incurring roughly the same practice expenses when furnishing behavioral health services to a patient at home via a telehealth as they do for services furnished in person. The other thing that they have introduced is that they continue to define the direct supervision to permit the presence and immediate availability of a supervising clinician through real-time audio and video interactive telecommunications through December 31st of 2024. Now, they changed the definition of direct supervision during COVID-19 PHE as it pertains to the supervision of diagnostic tests, physician services, and some hospital outpatient services to allow the supervising professional to be immediately available through the virtual presence using the 2-way real-time audio-video technology instead of requiring their physical presence. So pre-PHE, however, the direct supervision could only be met with an in-person, or immediate availability could only be met in person. So in this rule, they're proposing to continue to have that definition that was introduced during the during COVID-19 PHE. They are also proposing to be consistent with the telehealth policies that were extended through the 2023 Consolidated Appropriations Act. They're teaching physicians to use the audio-video real-time communication technology when a resident furnishes Medicare telehealth services in all residency training locations through the end of 2024. So this would be like sort of like a three-way telehealth consult in which the resident is providing the patient with a telehealth consult, and the supervising physician or the teaching physician joins that telehealth consult via telehealth as well. So they are proposing to introduce that to continue that till the end of 2024 as well. They have provided some clarifications on the remote patient monitoring or the remote physiologic and therapeutic monitoring in this physician's fee schedule. They confirmed and clarified that RPM and RTM services can only be furnished to an established patient. They also confirmed that the 16 days of data are required within a given 30-day period for the relevant RPM and RTM codes. This requirement also applies to the CPT codes of 98980 and 98981 for RTM treatment management services, not just to the supply of device and patient. Education setup codes as previously held. RPM and RTM cannot both be billed for the same patient in the same month, though either RPM or RTM can generally be billed with other care management services as long as time or effort is not double counted. The RPM or RTM, but not the both, can be furnished separately from services covered under payment for a global period as long as time and effort requirements are not, time and effort requirements are met. Now, CMS is also officially clarifying that RPM and RTM services may be furnished and reimbursed separately. And I just went over that. The most important thing is the separate payment for RTM and in the FQHCs and RHCs. Now, currently, the remote physiologic monitoring and remote therapeutic monitoring codes are not standalone billable visits in RHCs and FQHCs. So when these services are furnished incident to an RHC or an FQHC visit, payment is included in the RHC's all-inclusive rates. These are subject to payment limit or person visit payment under the FQHC prospective payment system, the PPS, which is lesser of the PPS rate or the FQHC's actual charges. Now, CMS is proposing that starting 2024, the RPM and RTM services will be separately payable to RHCs and FQHCs using the General Care Management Codes G0511. CMS is also proposing to classify the CPT codes 99457 and 99548 as primary care services under the Medicare Shared Saving Program for purposes of determining beneficiary assignments to Medicare Shared Services Program, ACO. CMS also proposes that RTM services be furnished under general rather than direct supervision when provided by occupational therapists or physical therapists in private practice. Previously, when provided by an occupational or physical therapist assistance, these services were subject to direct supervision, requiring the PT or OT to be immediately available. CMS is seeking a comment on whether to allow general supervision for a broader set of services provided by OTs and PTs as well. Now, there was another thing which they're doing in the physician fee schedule is they are asking for requests for information on digital therapies. They have a broad request. The exact verbology that they have used is that the opportunities and challenges related to our coverage and payment policies, particularly in regard to the type of practitioners and staff involved in furnishing RPM and RTM services, how these services are used in clinical practice, experience with coding and payment policies for these services, and challenges around claims processing, the need for further practitioner education and guidance around remote monitoring, and opportunities for future rulemaking around remote monitoring services. So they are interested in gathering information on that. And CMS is also interested in potential interplay between RTM for cognitive behavioral therapy and other digital CBT services. They are requesting, there is actually a request in this physician fee schedule to provide information on all of these digital therapies. Some of the other things which are included in this physician fee schedule, which will impact the delivery of care via telehealth. One of those is that this physician fee schedule proposes to continue to assign an active payment status to the CPT codes 98966 to 68, describing telephone assessment and management services provided by a qualified non-physician healthcare professional, not a telehealth service, for 2024 to align with the audio-only telehealth-related flexibilities that were extended via the Consolidation Appropriation Act of 2023. They are also proposing to increase the payment amount for the telehealth originating site facility fee according to Medicare Economic Index. So for the year 2024, the proposed payment amount for the telehealth originating site facility fee, the HCPCS code Q3014, is $29.92. They are removing the frequency limitations for certain subsequent inpatient visits, subsequent nursing facility visits, and critical care consultation services. These include CPT codes 99231 to 33, and then 99307 to 10. And they pay for telehealth services and skilled nursing facilities for critical care consultation services, including till the end of 2024. They are also proposing for codifying billing rules for the diabetes self-management training, the DSMT services furnished through telehealth, allowing the distant site practitioners who can appropriately report the DSMT services furnished in person, for example, the registered dietitians, nutrition professionals, physicians, nurse practitioners, physician's assistants, and clinical nurse specialists to bill the DSMT services furnished via telehealth, including when the DSMT services are performed by others as a part of the DSMT entity who do not qualify as a telehealth provider under the Section 1834 of the Act. Now, addition of the health and well-being coaching services to the list of covered telehealth services on temporary basis up until 2024, permanent addition of social determinants of risk assessment to the Medicare telehealth services list. CMS is also proposing to extend the current flexibilities for the opioid treatment programs to allow for assessment furnished via audio-only telecommunications through the end of 2024. Now, this extension allows for periodic assessment to be furnished via audio-only communications technology when video is not available, to the extent that the use of audio-only communications technology is permitted under SAMHSA and DEA requirements. This was a lot, but there is a comment period that is open for 60 days that will end on September 11, 2023. There have been some expected proposals in this physician fee schedule, but there are some new things as well, especially the RPM and the RTM addition for the FQHCs and RHCs as a separate billable service is, for some, can be a game changer. But again, if you are interested, I have provided the link in these slides, which will be shared with you at the end of this webinar, where you can go in and you can make the comments. Again, that time period is up until September 11 of 2023. We can actually take a break here and answer any questions that pertain to the federal legislative updates and the physician fee schedule. And then I will hand it over to Danielle to take a deeper dive into any regional updates.
And if you don't want to unmute yourself, you can always put those questions in the chat.
I don't believe that we have anything in the chat, Danielle, unless you're saying something that I'm not.
Nope. So we can get going on my section, but I will do my best to leave time at the end for folks to ask things. I know I can go on though, so we'll see. So we're gonna move on to some state updates now that we've gone over some federal telehealth updates. So it's important to remember that most of what we're going to talk about here related to reimbursement, coverage, billing, all that good stuff is going to be related to Medicaid. Private payer is extremely varied between insurance providers and individual plans. So questions about specific private insurers should really be directed to those insurers for the best and most accurate answers. Additionally, I do want folks to keep in mind that this presentation today is not going to be comprehensive. If you have questions that aren't answered here, it doesn't mean we can't help you. It just means we don't have time to cover every aspect of telehealth updates for every state in our region today. That would take much longer than I currently have. So please feel free to wait to ask any questions at the end, or to stick them in the chat while I'm speaking, and we can go over those. And if you'd like more time to think about questions, or if they occur to you later, please do feel free to reach out to us at info@umtrc.org. We're always happy to address any telehealth questions you have about this presentation or any other questions you have. So now that I've gone on my little spiel, let's start with the northernmost part of our region. So that's Michigan. So since our last state of the region, we haven't seen too much of a change in Michigan with relation to telehealth on a state-by-state basis. We have seen changes because of the end of the public health emergency, but that's something that has occurred on a large scale with every state, and federally, it's not just something that affects one state. So a lot of this will be review, particularly for the Medicaid portion if you did join us in April. But as of July 2022, nearly 3 million Michiganders were enrolled in Michigan Medicaid and CHIP. Michigan Medicaid is housed under the Michigan Department of Health and Human Services. So they should be contacted with specific questions about Medicaid coverage in Michigan. One thing to note about Michigan Medicaid is that the term telemedicine is used in all documents and coverage rather than telehealth. Despite the different usage of the word, the meaning is synonymous. So if you see things in Michigan referring to telemedicine, they still do mean telehealth. It's the same thing. So now we'll touch briefly on automatic enrollment changes due to the end of the public health emergency that did happen in May. Federal legislation has dictated an end to automatic enrollment, as well as certain eligibility considerations that changed during COVID-19. So Medicaid beneficiaries do have to renew their coverage this year, and that started last month in June in Michigan. So it is already in effect. Monthly renewal notices are going to be sent out 3 months prior. So those have already been going out with June as the renewal date starting. So next slide, please. So a quick note on Michigan's telehealth rules. This billing and coverage information that we're talking through today does come from the Michigan Department of Health and Human Services, and that's in their Medicaid provider manual. So telehealth guidance is integrated into that manual as opposed to being a separate guidance document. So if you're curious where this information comes from, this is a good resource. And as always, our partners at the Center for the Connected Health Policy also provide some pretty great information if you're curious. So next slide. So on March 2nd, 2023, Michigan Medicaid did release an extremely helpful bulletin that was created to update program coverage of telemedicine services after the conclusion of the federal COVID-19 PHE. And we are now in that time, the PHE did end in May. So, and this bulletin also clarified which other bulletins are now discontinued as of the dates indicated. So since we've passed May without any extensions, a lot of those bulletins that were effective, that were active during the PHE are no longer. So I'm not going to go over that entire bulletin here, especially since we did touch on it in April as well. But if you do practice telehealth in Michigan, I would really recommend that you follow the link here to Bulletin MP 2310 and go through some of the important highlights and information provided there. So the bulletin does go over general telemedicine policies, as well as determination for appropriateness and documentation. And then it also goes through prior authorization requirements, all important things to be aware of. So on the next slide, please. So it also talks through telemedicine reimbursement, as well as payment parity and audio only. And one thing to note about audio only, because this is something that folks do have a lot of questions. In Michigan, preference is given to the traditional video visits with the AV components. But if not available, MDHHS will allow audio only coverage for certain telehealth services, and you can see which services exactly that covers in the bulletin. And those are primarily behavioral health services, because those are the ones that we've seen can be delivered with audio only with the most with the least reduction of effectiveness. So it also goes through billing requirements and some correct coding requirements, equivalents, all that good stuff. So next slide. So quick note of private payer. The largest private insurer in Michigan is Blue Cross Blue Shield. That does not mean it's the only one, but questions about private insurance coverage, like I said earlier, should be directed to the insurer, because things vary so greatly between insurers, as well as just between plans and type of coverage. So next slide. Okay, so we're going to talk now a little bit about pending legislation that is currently relevant to telehealth in Michigan. And one thing I will say when we're talking about legislation today, if you're curious about legislation in your state, this is not a full list. The Center for Connected Health Policy, which is a good partner of ours, it's a member of the TRC, the larger Telehealth Resource Consortium. They do have a tracker for all relevant pending and legislation for all of our states. So if you have more questions about this, that can be a great resource. But first up, some of our relevant pending legislation is Senate Bill 365, and that does define telemedicine for eye care providers, so optometrists, and defines the conditions that can be serviced through telemedicine. And now House Bill 4579. And this one is definitely one to keep an eye on, because it has introduced the concept of payment parity for telehealth. And that is something that we love to see, because that makes it easier to provide telehealth. And both of these bills at this point have been introduced, so they have not gone to chamber yet, but we're keeping an eye on them. And then House Bill 4577 would allow telehealth to be used for pre-admission screening for community mental health programs. And that's another bill that at this point has been introduced. It hasn't gone to chamber yet. So next slide. So next up is my home state of Indiana. And like Michigan, there haven't been too many Indiana specific updates since March. We have, like I said, we've seen the changes brought about by the end of the PHE, but that's been universal everywhere. But for a quick overview of Indiana coverage, as of October of 2022, nearly 2 million Indiana residents were enrolled in the Indiana Health Coverage Program, so IHCP, and a number of those are basically just Indiana Medicaid. So now we'll touch briefly on automatic enrollment changes. So in Indiana, automatic enrollment provisions have ended. Full coverage IHCP members no longer have continuous eligibility like they did during the PHE. So in order to maintain their coverage, they're once again subject to the same standard member eligibility rules that were in place prior to March of 2020. Next slide. Sorry, just a second. So for Indiana's telehealth rules related to Medicaid, billing and coverage information is in the Indiana Health Coverage Program's Telehealth and Virtual Services Manual, and there's a link to that here. So if you're curious where this information comes from, this can be a good resource, and they have specific instructions for telehealth services, non-healthcare virtual services, as well as other special considerations. So next slide. So some Indiana Medicaid updates. So last month, we did see a bulletin released in Indiana that explained coverage for mobile crisis intervention services. This is not strictly telehealth, but we are talking about mobile services. So we felt this was important to touch on. So as part of the 988 Suicide and Crisis Lifeline Initiative implemented by the House, the Indiana Health Coverage Programs will be adding Medicaid coverage for crisis intervention services rendered by mobile crisis teams, designated by the Division of Mental Health and Addiction, so the DMHA. The crisis intervention services will be reimbursable when rendered by an enrolled community mental health center with a DMHA designation as a mobile crisis unit. So some of those covered services include triage and screening, assessment, de-escalation and follow-up stabilization services, safety planning, and peer recovery support. So if you're somebody who is operating in Indiana and you do have work related to crisis intervention, this is something that's important to keep in mind. So next slide. So an Indiana highlight. So cross-state licensure is something that we talk about often. So there's some good news related to cross-state licensure in Indiana. So Indiana has historically been a bit restrictive with originating sites for telehealth providers, but legislation earlier this year that lessened restrictions on telehealth providers who don't have residency here was passed. So Indiana House Bill 1352 was passed this May, and it states that Indiana Medicaid cannot require providers to maintain a physical address within Indiana to be eligible for enrollment as a Medicaid provider. And it is important to note, though this passed in May, it does not go into effect until January 1st of 2024, so the beginning of next year. I won't read all of the text here, but essentially starting next year on the 1st, providers don't necessarily need to have physical residency in Indiana to provide telehealth. That being said, the Indiana Professional Licensing Agency, the IPLA, does have some restrictions around this, but overall it's going to be less restrictive going forward. So if you or your organization is not located physically in Indiana, that doesn't mean that you can't provide telehealth according to this new law that goes into effect next year. So next slide. So Indiana private payer, our largest insurer here is Anthem Blue Cross Blue Shield. Same disclaimers apply for reaching out to your insurer with private insurer questions. So next slide. So we're going to talk a little bit about some enacted pieces of legislation in Indiana. The first up is House Bill 1352, and that's the one I mentioned that deals with telehealth services and locations as well as cross-state licensure, so I won't belabor that. And then Senate Bill 160 is enacting the Counseling Licensure Compact here in Indiana. And then Senate Bill 73 is enacting the Occupational Therapy Licensure Compact. So these have been enacted as of now. So next slide. And here's some pending legislation. We did mention this in our last presentation, so I thought it would be good to talk about progress, and there has not been any as of now. So this is Senate Bill 190, and that would amend the definition of prescriber to include physician assistants. So we haven't seen any movement on this yet, but we are keeping an eye out. So next slide. Going right along, let's move into the state of Ohio. So more than 3 million folks in Ohio are covered by Medicaid through a network of over 165,000 providers. And Ohio Medicaid is housed under the Ohio Department of Medicaid, which makes sense based on the name. So now we'll touch on those automatic enrollment changes. Like I said, this is another one where the end of the PHE means that automatic enrollment has come to an end, as well as certain other eligibility considerations. So Ohio Medicaid did resume normal operations on February 1st of 2023. So this happened a while ago. But it is important to keep in mind as we do see members being disenrolled from the program if they are not aware of that. So beneficiaries should keep their contact information up to date at benefits.ohio.gov to make sure that they are not erroneously taken off of that insurance. So next slide. So the Ohio Department of Medicaid has their billing and coverage information related to telehealth. available in their telehealth billing guidelines document, and that can be found online. And it has pretty comprehensive coverage for a variety of specialty locations and providers. So as always, if you're curious to learn more about the billing guidelines related to telehealth in Ohio, as well as some coverage information, this is a great place to look. So next slide. So our highlight from Ohio, I do want to emphasize before we go into this, that this is something that has been proposed, not enacted as of now, but it's important to be aware of changes that are potentially coming to Ohio Medicaid. So Ohio is proposing rules in its state budget related to Medicaid that would make it so able-bodied Ohioans 55 and younger would need to either work or study for at least 20 hours a week, with exceptions for mentally ill folks as well as some others, as a term of enrollment for Medicaid. So with some exceptions, unless you are working or studying 20 hours a week, you would not be able to be enrolled in Ohio Medicaid. So this is something that would need to be approved by the federal government to go into effect. And if it was, it would not be enacted until 2025, but this is something that could change eligibility for Medicaid in a big way. So it's something to be aware of if you're located in Ohio. So next slide. So the largest private payer in Ohio is Atena. Never sure if I say that right, but we'll go with that. Same disclaimers apply here. So next slide. So some pending legislation in Ohio. First up, we do have Senate Bill 90, and that would enter the Social Work Licensure Compact. And I believe this one is in first or second chamber. I apologize, it's not on the slide. And then we have Senate Bill 28, and that would enter the Physicians Licensure Compact. I'm almost positive that one's in first chamber. And then House Bill 136, which would authorize the operation of remote dispensing pharmacies. And that is one that I believe has been introduced at this point, but has not moved further as of now. So next slide. Okay, and last but certainly not least is our westernmost state of Illinois. So Illinois Medicaid is housed under the Illinois Department of Healthcare and Family Services. And like our other states we talked about today, Medicaid beneficiaries will have to renew their coverage this year. And in Illinois, that did start in June, so last month, with renewal notices starting to be sent out in May, as Illinois resumes Medicaid eligibility redeterminations to comply with federal legislations. So there are resources for beneficiaries to check their renewal status. And it's also important to note that Illinois Medicaid offerings include all kids and family care. So next slide. So our highlight from Illinois is related to social work via telehealth. So thanks to House Bill, 4797, we've seen some important clarifications related to restrictions related to social work being done through telehealth in Illinois, particularly when we're talking about practice over state lines. So I'm going to go over that briefly here. So the text of this bill clarifies a social worker can continue to provide services via telehealth when their client is temporarily in Illinois, even if the provider themselves are not. So as long as there's not more than 5 days of service being provided in 1 month or 15 days in the entire year. And this applies only to those who already have established patient-provider relationships. So you wouldn't be able to start with a new social worker out of state under this rule. So this means if a client is in Illinois on a trip, they could continue to see their social worker via telehealth as long as those restrictions I mentioned earlier are followed. There are also specific rules in this bill for college students. So non-residents are able to continue telehealth with their social workers as long as that relationship has already been established. So this bill has added some important clarification to telehealth and social work within the state. So next slide. Excuse me. So like in Indiana, the largest slide is Blue Cross Blue Shield. It's okay, you can go forward. And now we're going to touch on some enacted or this should be pending legislation. I think I switched those titles around. So first up is Senate Bill 1721, and that's the Hearing Instrument Act. and that would say that patients 18 and older can be evaluated for a hearing aid or hearing instrument via telehealth before receiving that prescription for a hearing aid that's currently in second chamber. And the Telehealth Athletics Trainers Act, and that's a Senate Bill 1585, would amend the Telehealth Act to include athletic trainer as a healthcare provider. And then the Naturopathic Medical Practice Act, that's House Bill 3721, that's been introduced, but that would create the Naturopathic Medical Practice Act and provide a definition of telehealth or telepractice. And note that licensees would not be prohibited from using technology to provide services. So next slide. And this is the one that should be enacted legislation. I apologize again. So Senate Bill 1913, and that bill has applied the requirements around telehealth found in the Insurance Act, also applicable to the state Medicaid program. And then Senate Bill 2057 has amended the Illinois Occupational Therapy Practice Act, and that's made some changes to some definitions. So those are things that have been enacted recently. So next slide. So those were our state updates. Like I said, please feel free to reach out with any questions, comments, concerns. We're always happy to address those for you. So a few upcoming regional events that we have going on in the UMTRC region. So in Michigan, we have Beyond the Scene, which is a conference for first responders, and that's happening in August. We also have the 2023 Michigan Rural Health Clinic Practice Management Workshops, and that's happening on August 8th. In Ohio, we have the 2023 Ohio Rural Health Conference, and that's happening on the 3rd and 4th. The UMTRC will be there. I'm actually presenting. So if you're there, please stop by, say hi, listen to me talk about Ohio telehealth. And then we have the 2023 Annual National Association of Development Organizations Training Conference. That's a mouthful, in November. And then in Illinois, we have the Illinois Rural Health Association Conference at the beginning of August. We also have the SIU School of Medicine, the 2023 Telehealth Conference that's happening on August 30th, and the UMTRC should be exhibiting there. So if you're attending, we will see you. And then in Indiana, we have the IRHA 2023 Fall Forum, and that will occur on September 12th. Always a great place to hear more about rural health. And then in November, we have the 21st Annual Indiana Public Policy Forum. Great way to stay updated with policy if you're located in Indiana. So next slide. So a couple of upcoming UMTRC events. So our July office hours are actually this Thursday at 11 a.m. EST. So if you've got questions about telehealth, you can drop in and let us know. We do ask that you register for that beforehand, just so we know how many folks we should have available to answer those questions. And then our August webinar over telehealth and substance use disorder will take place on August 14th at 12 p.m. EST. And just a note, that's through a collaboration with Ohio Source. So it will be Ohio focused when we talk about the state-by-state basis, but there will be a lot of general information just about telehealth and substance use disorder and how those connect. So please feel free to register for that at the link here and visit our website to see all of our upcoming events. All right, next slide. And yeah, that is what I have. So if you have any questions, please feel free to put those in the chat or take yourself off mute. And I did see in the chat that we put out our evaluation report. We would love it if you could take a second, I promise it's short, and answer that evaluation for us, just so we know how we're doing and how we can do better for you guys in the future. Okay, I don't see any questions, Amna.
I don't either. After this presentation, even if you have your questions, you can reach out to us via any of these venues and we can get back to you. Just one thing I wanted to emphasize, the virtual office hours are what exactly they say. Those are office hours. We do not have a prepared presentation for those hours. So if you are looking at prepared presentations or webinars, then those are the webinars that are as listed. Just wanted to make sure, because we've had people jump on thinking that there will be a presentation, but those are just for you to ask any questions or discuss any situation that you might have with your telehealth practice. Well, I think we can give you back 6 minutes of your time. So since there are no questions, thank you so much for joining us. Stay tuned to the next State of the Region. Hopefully we'll have finalized physician fee schedule by then, and also some other, if there are any legislative and policy updates in our states. Again, thank you so much for joining us, and do visit our website at theumtrc.org.